talk to you about how female athlete triad is identified and treated in collegiate athletic populations. So to give you an idea of the significance of triad, I wanted to start with this statistic. Female collegiate athletes are 2 to 3 times more likely than their non-athlete college peers to meet the criteria of an eating disorder. As we go through today's presentation, by the end of this, I'd like for you to be able to identify the components of female athlete triad and their epidemiology, to understand the current screening and management guidelines, and also to be aware of the interdisciplinary team that's involved with providing care to these high-risk athletes. We will start with looking at the background information and prevalence of triad, then screening and assessment guidelines, then we'll look at the treatment team involved with care, and also the intervention techniques, and finally we'll talk about prevention. So female athlete triad is comprised of 3 interrelated conditions. The terminology has changed over time, but currently the most widely accepted and strongest scientific evidence points towards these 3 criteria. Low energy availability, that could be with or without disordered eating or an eating disorder. Menstrual dysfunction, that could be amenorrhea or oligomenorrhea. And finally, low bone mineral density. Energy availability is really the cornerstone of this syndrome, and it affects menstrual status. And the energy availability and menstrual status both then affect bone health. Does anybody know what a Z-score is? Anybody? Anybody? Can anybody tell me what a Z-score is?
Isn't it like how far it is from the average?
Right. So a Z-score compares the condition of a person's bones against the condition of someone of the same age. So with athletes, we expect to see higher bone mineral density because they participate in weight-bearing exercises. So while the general population, we might say a Z-score of -1 to -2 is normal, with an athlete, -1, we're talking about a low bone density at that point. And then once an athlete's Z-score is -2 or lower, at that point we're looking at a diagnosis of osteoporosis. So female athlete triad is currently recognized as a spectrum, and the goal in framing the conditions this way is to highlight the importance of recognizing those subclinical presentations in order to allow for early intervention. And when I say subclinical versus clinical, subclinical for energy availability would be any kind of energy deficit, whereas a clinical presentation of energy availability issues would be an eating disorder. With low bone mineral density, a Z-score of -1 is subclinical, whereas osteoporosis or stress fracture are going to be clinical. And I also want to note that an athlete can be diagnosed as having triad without necessarily presenting with all 3 of these components. And also, even if they don't have all 3 of these conditions, the same negative health impacts are associated with it. So what are we worried about with triad? Well, depending on your role as a dietitian, you may or may not be overly concerned with the first bullet point, but the negative impact that triad has on performance is probably going to be the thing that the athlete cares about the most. When it comes to health, though, there are numerous body systems affected, in addition to the psychological well-being of the athlete is affected. Generally, the most common injury we see amongst these athletes is going to be the stress fracture, and sometimes that might be the first real indicator that something is going on. So how prevalent, what is the prevalence of triad? Currently, the true prevalence of triad is unknown. There's been a number of studies across various populations, but there are methodological limitations that make the study of triad quite difficult. Research often fails to evaluate both those subclinical and clinical presentations and outcomes of triad, and there's also a notable lack of research when it comes to energy availability in these prevalent studies. One study conducted by Catherine Beals and Amanda Hill at the University of Utah and published in the International Journal of Sports Nutrition and Exercise Metabolism surveyed 112 collegiate athletes to look at the individual components of triad. From their study, they found that 8.9% had primary amenorrhea, 21.4% had secondary, 20% had signs of disordered eating, while 2.7% had an eating disorder. In this case, anorexia nervosa or bulimia nervosa. 9.8% had a Z-score of less than -1, and 1.8 had a Z-score of less than or equal to -2. So how do we screen for triad? Well, currently all NCAA Division I universities, and really most schools that have any kind of athletic program, require that all their athletes complete a pre-participation survey. This is an ideal opportunity to screen for those risk factors associated with triad, but there are some major issues here. First of all, most of the universities don't have a standardized form. Some universities allow for a family physician to provide and complete their own form for the athlete. The Female Athlete Triad Coalition has developed 12 recommended screening guidelines to include on questionnaires like this, but most NCAA universities either neglect to include these questions or only include a portion of them. I pulled these sample screening questionnaires from the questionnaire that athletes here at Purdue complete. Do you worry about your weight? Do you limit the food you eat? Do you have monthly menstrual cycles? And have you ever had a stress fracture? These questions are designed in a way to directly and indirectly assess an athlete's risk for triad. While screening is a vital component, it's not meant to be a diagnostic tool in and of itself. The goal with screening is to identify those athletes that are at risk, then to be able to get them to the correct individual to allow to get a better picture of what's going on. So I surveyed sports RDs at a number of universities. My respondents included sports RDs from the University of Tennessee, University of Ohio, IU, Harvard University, and then in addition to how my firsthand knowledge of how we do things here at Purdue. The process of assessment and screening is pretty similar. Either through the screening questionnaires or referral from a physician or an athletic trainer, those athletes that are flagged as at risk are referred to a sports RD. And the sports RD will then complete a thorough nutrition assessment to get a bigger picture of what's going on with that athlete. Depending on the presenting symptoms and the severity, that sports RD will then have the athlete do a dietary recall or complete a food record, generally a 3-day food record. If there is energy availability issues that are a result of a knowledge deficit, the RD will work to educate that athlete on what their needs are to support their training needs. Their training regimen. If there is disordered eating, but not necessarily a full-blown eating disorder, then the RD will counsel that athlete and try to figure out what's motivating those undesirable behavioral habits. If there is an eating disorder, at that point, if the RD is inexperienced or feels uncomfortable handling triad from a nutrition standpoint, at that point she'll refer out, he or she, and they will also initiate a coordination of care with an interdisciplinary treatment team. That treatment team involves these 3 key players: dietitian, a physician, and a mental health professional in cases of eating disorder. Other specialists like a gynecologist or endocrinologist may be necessary, and then support's also needed from coaches, athletic trainers, family, and friends. But these 3 key players will work to assess those presenting symptoms of triad and establish the correct intervention. So if an athlete has amenorrhea, the physician might prescribe an oral contraceptive or get the athlete started on hormone replacement therapy. For issues of low bone mineral density, the athlete will get started on a vitamin D and calcium supplementation regimen. But the single greatest intervention to treating these athletes and getting them healthy is energy repletion. Working with an athlete to understand what an ideal balanced diet looks like to support their training is key to getting these athletes healthy and returning to play. Care is individualized, and the specific treatment plan will depend on the athlete, their sport, and where they're at in their competitive season. Prescribed energy changes to meet a weight gain goal or a target BMI usually are a 20 to 30% increase of calories over their baseline energy needs. And this is accomplished over a period of time. So for an athlete that has an energy deficit and is currently consuming 2,000 calories, this would represent an increase of 200 to 600 calories accomplished over several months. With those athletes with eating disorders, though, even smaller steps are necessary. So with that, the goal is to normalize those pathological eating behaviors, to minimize their dieting attempts, and to overcome their negative beliefs they have associated with food and body image. While a solid treatment plan is ideal to getting these athletes healthy, even more so, the goal here is prevention. But prevention relies on education on the part of the athletes, the coaches, healthcare professionals, and we have a real big issue here. One study conducted in 2014 by Katie Brown, Heidi Wingreen, and Catherine Beals and published in the North American Society for Pediatric and Adolescent Gynecology, surveyed 240 athletes and their coaches from a variety of sports to get a feel for their knowledge of Triad. Of the 240 athletes, only 9 of them had ever heard of Triad, but none of them could identify the components. Of their coaches, only 3 of them had ever heard of Triad, and only 1 could correctly identify all the components. While this data is troubling, let's look at a study regarding the multi-specialty physicians and their knowledge of Triad. So this study was conducted by Emily Curry in 2015 and published in Sports Medicine magazine. It was conducted at 3 different academic teaching hospitals amongst physicians from a variety of different specialties. They were all sent out a 8-item questionnaire. The questionnaire was set up so that it would first ask, have you ever heard of Triad? A no response would end the survey there, while a yes response would continue on into the rest of the components of Triad. 931 physicians responded, and of them, only 343 checked yes that they had heard of Triad. Of those 343, 70.8% were able to correctly identify the remaining components of Triad. Also with this, only 49% of these physicians reported that they would feel comfortable either treating or referring an athlete that presented with Triad. So from these 2 studies, it's really clear that a lot of work still needs to be done when it comes to education in order to allow for intervention and treatment in an interdisciplinary environment. And so I challenge each of you moving forward to help carry that torch. Well, I could talk about Triad all day. It's unfortunately coming to time where my spiel is almost done. So we'll go back and look at our learning objectives. As I said in the beginning, I really hope that by the end of this, you'll be able to identify the components of Triad and epidemiology, to understand current screening and management guidelines, and then also to be aware of that interdisciplinary treatment team. And at this point, I will have you guys go ahead and flip over and we're going to start working on that post-test and evaluation. But I wanted to leave you with this one final take-home message. With female-athlete Triad, it is vital that we identify and intervene. Ignorance of Triad will lead to injuries. Thank you. Questions?
So I had one. I'm not quite sure if you mentioned it or not, but what are some sports with this is commonly associated with?
So it's 2 to 3 times more likely that Triad occurs in our lean, aesthetic sports or sports that have a weight gain goal. So gymnasts, dancers, swimmers, cross country, it's going to be most prevalent in those kinds of sports, whereas basketball, soccer, those sports where weight's not as much of an emphasis, it's less likely there.
Oh, okay, thank you.
Why is the BMI a potential diagnostic criteria lower than the normal body weight?
So the question is, why is the BMI for a female athlete Triad not the same as what a normal body weight would be? Well, because we're looking for underweight individuals, and those are just potential diagnostic criteria. It's not necessarily, like I said, it's a spectrum, so there's not necessarily hard and firm what those are, but we tend to see Triad having a more elevated risk of Triad and these negative health outcomes with individuals that are underweight. Any other questions? All right, well, I will give you some time to finish that before we start with the next presenter. Thank you guys, appreciate it.